Hello, everybody. My name is Callie McAdams. I am a breast surgeon at Grove City, and I'm here with Dr. Padilla to talk about breast cancer screening, what's new, and why it matters. So, Dr. Padilla, I'm sure most of you know her. She did her medical school at Northeast Ohio Medical University, her residency at St. Elizabeth Health Center, her breast fellowship at Cleveland Clinic, and she is a board certified general surgeon. What you will not see on this list, but you know if you've met her, is that she comes to work every day with poise and purpose and probably the biggest heart of anyone I've ever met. So I'm very thankful that she's my partner. I would let her take care of me and all of my family, and I think that says enough about her. So without further ado, I will let her go through her talk about screening.
Thank you, Dr. McAdams. That means a lot. So thank you everyone for joining today also. As she said, I'm going to talk a little bit about breast screening, what's new, and then why it matters. So let's start with what's new. In order to actually understand what's new, we should probably look at the past. And so if you looked at this slide, the first thing that we did and the first type of x-ray was all done on film. And I'm going to date myself here, but shows like ER would have George Clooney, for example, walking around the emergency department with a plain film. And ultimately we found things on that. And to be honest, I don't know how we found anything looking at a light box, but ultimately it was better than nothing. So mammograms really started just like regular x-rays as plain films or film mammography. And then as technology advanced, we started going to digital mammograms. And digital mammograms, as this picture shows, is really where computers came into play. And when you have a computer, the quality is so much better, the visibility is better. And then ultimately, probably in the last 5 years, it has become more standard that we now have the ability to do 3D mammograms. 3D mammograms are actually are the same machine that you would have a digital mammogram done, but it is the software that the machine runs on that actually gives us a 3D image. So why does that matter? And why is this important when you're talking about mammograms? And why is it important that technology matters? Well, the reason why is because there's something called breast density. And although most of you have probably heard about this, breast density does not make you an alien. I sit in extremely dense or category D, and I swear to people I'm not an alien. But ultimately, it is normal. 50% of the population has dense breast tissue. And so the reason why we wanted to get better at visualizing breast tissue is so that we get better at visualizing dense breast, because this may be a little hard to see, but if you look at A, there is a star, and that star is to signify potentially where a cancer could be in someone's breast. And if you walk it down between B, C, and D, that star is actually not that easy to see on D. And so, for lack of a better way to describe it, cancers show up white and dense breast tissue shows up white. So the question is how is a radiologist going to see a white cancer in the midst of a bunch of white tissue? So density is important, but technology advancing to look at dense breast tissue better is extremely important for early detection. So again, 50% of the population has dense breast tissue, and it is somewhat based on hormone levels in your body. I call breasts like a muscle. The more you work it out, the more tone that it stays. In breasts, the more you work it out, the more perky that it stays. But if you think about menopause, when all of us lose estrogen in our bodies, our breasts really get saggy and droopy. And it's because all of that really nice, dense tissue gets replaced by fat. So hormone levels are part of it. And what that means is as we get older, your density should change. It's not uncommon for a young woman to have dense breast tissue because ultimately they are meant, if the reason God gave us breasts is to breastfeed, right? So they should have the ability to have some structure in them to make milk. But I'm hoping that most of you are not deciding to breastfeed when you're postmenopausal. So ultimately, it is somewhat based on hormone levels. But again, like we talked about when you saw that star, there is a decreased sensitivity with mammograms. And what that means is basically that it's harder to find things when the area is dense. So I know we'll do a question and answer session, and I would normally do this as kind of like a raise your hand, but how many of you, and I'll ask this when we become more in that session, is how many of you have you been told have dense breast tissue? Because in 2014, that is when it became law. So we've also always actually, for since the dawn of time of mammograms, reported density. That's not new for healthcare providers, but it is new for patients because it's only been about 10 years that it's been the law for Ohio. Now, the flip side of that is we now give letters to women to say, by the way, your tissue is dense. You should talk to your ordering provider, primary care physician, OBGYN, breast surgeon, um, for more information. But what that letter doesn't tell you is that it's okay and that you're going to be fine. But ultimately, it is important to know if you have dense tissue because we need to potentially do something different. And then the last bullet point there is I will just make a comment that the American College of Obstetrics and Gynecology did publish a study approximately 10 years ago that showed that you could increase your risk of developing breast cancer by 2 times by having dense breast tissue. So again, like that slide showed, why does this matter? And it matters because there are other things you can do. So having dense tissue is common and it is normal. And we also know that regular mammograms do great, but they don't do the best job at looking at dense tissue. So the way that I usually talk about this is that some genius radiologist said that there has to be something else we can do. And so, two things that have been added to regular screening mammograms are something called an automated or whole breast ultrasound or an abbreviated MRI. And so, many of you that have probably had dense breast tissue or even had mammograms that showed something and you needed to have extra imaging, an ultrasound was ordered. And so, I get a lot of questions in the office of like, I have this really dense tissue. I always get called back. Can't you just add an ultrasound? And the answer in that thought process is actually really logical, but in the past, ultrasounds have never been used as a screening tool because, in order to be considered screening, the definition is that it has to be done the exact same way, the exact same time, and it has to be generalizable across the country. And if you think about for any of you that ever had an ultrasound, it's actually done by a human. And in medicine, human error is not something we're willing to accept. So ultrasounds really have never been part of screening tools because it has too much human error potential. Because even having the same ultrasound done by the same tech the next year, quote unquote, may not give you the same result. So this genius radiologist I talk about, created an automated version or a whole breast ultrasound where it actually has some of a computer that takes the majority of the responsibility rather than a human, which then allows it to be more accurate. And in women with dense breast tissue can actually really improve visualization by about 35%, which when you're trying to find a cancer, that's really important. So again, as the thing saying asterisk, adding these two things to your screening mammogram can improve and increase visualization of dense breast tissue. These tests are done at the same time as your mammogram. So most of all studies that are done looking at this show that having the same radiologist read the imaging, your ultrasound or your MRI, and your mammogram at the same time for density will give you the most accurate representation. So again, I keep saying this, but like, why does it matter? So if we look at breast cancer, kind of some stats, 1 in 8 women will be diagnosed with breast cancer in their lifetime, even without a significant family history. It's higher actually than anywhere else in the world. In 2024, per the Susan G. Komen website, there's estimated 310,000 new breast cancers will be diagnosed this year, which is alarming. And the most common time to get breast cancer is in your 60s and 70s. So it's not normally a cancer of a young woman, but that doesn't mean we don't know young women that have been diagnosed or that it's not important to get screened. And so the recommendations are that you get a mammogram starting at the age of 40. And the reason why is because if a cancer were to be diagnosed at a young age, getting a mammogram starting at that age does provide a survival benefit, meaning that if that cancer is found, it would be caught early enough that it doesn't affect you long term. And so I want to kind of take a little bit of time to talk about this last bullet point where it says that it finds changes in breast tissue. I hear a lot of women that have heard stories or have friends or personally, their cancer wasn't caught by mammogram. And although that's not common, it's actually not that rare. So mammograms are meant to find changes in breast tissue. And that's why we do mammograms every year so that a radiologist has all the other images and all the previous mammograms to look at to find those very subtle changes. But breast tissue is not, they're not dead pieces of fat that sit on top of us. They actually do change, and as they should, because they're live pieces of tissue. And so ultimately, sometimes cancers can grow in the breast, but they're either too small or they're just really sneaky and they haven't made a change in the mammogram enough for a radiologist to find it and call it. So you're right, it's not common for cancers to not be found on mammogram, but it's also not unheard of. And you're going to meet someone, if you don't already, that it's not that the mammogram missed it, it was that the cancer was too small or didn't cause any changes in the breast tissue for a radiologist to need to further investigate. So, why is it important to get screened and why is it important to find these things? And the reason why is because breast cancer, like this picture shows, is truly a progression from a normal cell to a cancerous lump. It doesn't go from normal to invasive cancer overnight. And so, if you look at this diagram, as you kind of work your way down, you go from a normal duct, and then you start getting these funny cells, and then even funnier looking cells. And then the very last one is where these funny cells have finally left the wall of the duct or lobule. And that is what we call invasive cancer. Now, invasive does not mean that it has gone to other organs. What I usually say is they were in the house, they're now in the yard, and then we try to catch them before they go down the street. So one of the earliest stages of breast cancer that we try to treat is something called ductal carcinoma in situ, or DCIS. And the in situ is the important part because in situ in Latin means in place. And so if you spell that out, that means that there are ductal cancer cells present, but they are in place, meaning they have not yet left the wall of the duct. Do you mind going to the previous slide real quick? So if you look at this DCIS written there, you can see that the duct is full of some weird looking cells, but it is not like the one on the next immediate right where the cells have actually left the wall. Thank you. You can go back to the other one. So like this picture shows, one of the things about it is that we call DCIS is almost like grains of sand. So there's no tumor. A tumor is when when those cells have actually left the wall of the duct and created an actual mass. But these are cancer cells that I would kind of call like a subway system. Our breasts are full of ducts and lobules all over the place, and they are a subway system with all of these interconnections. And sometimes cancer cells can march down the subway, but as long as that subway doesn't, breach the wall like they do in the movies, it's okay that those cancer cells are there, but they haven't made a tumor. So there's actually no mass or no palpable or something you can feel when you have ductal carcinoma in situ. So really the only way to find this theoretically is by mammogram. And as this mammogram shows, there's a whole bunch of white specks everywhere. And those white specks are also extending to the nipple. And you can kind of see the nipple in this mammogram as the little circle that's just outside of where the breast tissue is. But you can see that those ductal structures all converge to the nipple, and those white specks are making their way all the way to the nipple. So in contrast, then, we talk about an invasive malignancy, which is where actually a tumor is present. And when we do mammograms, we hope to find tumors that are much smaller than this. But this mammogram I thought was really telling to say this is what a tumor looks like in relation to grains of sand. Um, the thing about when you have a tumor is that once it leaves the wall of a duct, then it has a chance to go to lymph nodes. So there's a potential for increased risk of lymph node involvement. That's what LN stands for. And the more advanced the breast cancer is, the more treatment you need. One thing about breast cancer, and the reason why we care a lot about catching it early is, like the previous slide showed, the earlier that it is caught, the less treatment that you need. So, and I know this probably isn't going to project. It was drawn to scale, but I know on this it's not as it doesn't always project that way. But this is the size of what a lump is found on exam versus the size of a lump that is found on mammogram. Technically, based on this is considered between a stage 1 and a stage 2 breast cancer. And ultimately, although prognosis, meaning long-term outcome, is not that different for stage 1 and stage 2, depending on the type of cancer, things like chemotherapy could be recommended for a stage 2 and not a stage 1. So although exam is important, we still absolutely recommend routine mammograms because you want to find a cancer before you can see or feel it. So going back to this was actually on the American Cancer Society website. And so yes, we talk about prognosis, but I'm going to say it again. What matters in the way that a cancer diagnosis affects your life is the stage in which you were diagnosed. And so when we look at stage 1, stage 2, stage 3, stage 1 has a 98 to 100% 5-year survival rate. Now that doesn't mean you're going to die after 5 years. We know that if breast cancer ever were to come back, it most likely is going to come back within the first 5 years. So if you get through the 5-year mark, the risk of anything bad happening except like exponentially goes down. So in medicine and for us, we really need to see what is your risk of this coming back and how is it going to impact you long term over the next immediate 5 years? Because once you hit that, then it's really good. But if you look at these numbers, it's not that bad actually. I mean, stage 1 has a 98 to 100% 5-year survival rate. Now I know stage 3, it does show 66 to 98%, but I'm going to kind of focus on the 66%. That means 2/3 of people will still do great, but that means 1/3 won't as well. And unfortunately, we never know who's going to be in which of those categories. So the earlier that it is caught, the less impact that it has on your long-term outcome. And so we were talking about mammograms. So if we're talking about screening, then we also need to talk about other modalities that have been shown to look at breast tissue, and one of those is thermograms. And as the name says, thermo is based on heat signals, and the idea behind it is that, if we think about like high school biology, um, cancers create their own blood supply, or something called angiogenesis. So the idea is that if you can do heat signals, can you potentially find a cancer based on its heat signal? Can you find it at that microscopic level where it's starting to create a blood supply to then allow it to grow? So the idea is that it potentially can catch cancer cells earlier than mammograms because you're basing it off of blood supply versus size of tumor. But what's interesting in breasts is that breasts are really vascular, meaning they have tons of blood supply and they're actually hormonally based. And so I didn't put the picture up here, but there is a thermogram. I have an example of a thermogram that was meant to find a cancer in a woman with extremely dense breast tissue. And with extremely dense breast tissue and a lot of vasculature and a lot of changes and a lot of heat signals, unfortunately, that cancer was not detected. So I would say thermograms are okay, but the second bullet point is probably the most important. The only studies that have ever been done with thermograms have been done at the same time as a screening mammogram, and the same radiologist was reading the thermogram and the mammogram at the same time. They have never been shown to have any use by themselves. Thermograms are fine, and they actually are becoming more and more popular. There's more studies coming out. There's more people that are investing technology, time, and money. So I think thermograms may eventually, but as of right now, the only time a thermogram can be done or will be accurate is if it is done at the same time as a mammogram and the same radiologist is reading it. So there was, I would say a couple of years ago, there was a thing on the news basically that said that the American Cancer Society does not recommend clinical breast exams. And yes, that probably gave everybody in medicine extreme anxiety. And so what they were getting at basically was getting a breast exam, is that actually going to detect breast cancer enough and early enough that is there a survival benefit? Meaning, like, are we putting women through these exams, et cetera? And does it do anything? And I'm gonna tell you that, and it might be my soapbox that I die on, that yes, I fully believe in mammograms and exams. So the reason why I say this is I'm gonna go back to, although not common, it is not rare that women's cancers are not detected by mammogram. The mammogram is not the be all and end all of making sure. And so we at this institution, we have general surgery residents and family medicine residents and internal medicine residents. And when I give lectures to the internal medicine residents, general surgery residents, et cetera, I always tell them to do an exam, because just because your patient presents with a normal screening mammogram does not mean that their breast exam is normal. There is one very specific type of breast cancer that does not show up on mammogram, but is absolutely found on clinical exam. And so I would say that as a woman, it doesn't have to be a breast surgeon, but as a woman, if you have breast tissue, you should be going every year to have a breast exam to make sure nothing is being felt. And the third point I will make in what's listed here is that we've kind of gotten away from calling them self-breast exams, because that word with any of us kind of gives us, there must be a pass fail, right? If you have an exam, you either do it right or you don't do it right. And ultimately, there is no right way to do it. I will be honest, I do my breast exam on myself much differently than I do it on someone, and I do them every day. And feeling something on me is actually very different than feeling it on someone else. So I usually say have self-breast awareness. We wash ourselves the same way every day. When you take that washcloth, loofah, etc., you'll notice if something feels different up here. But also look at yourself in the mirror. Breasts are truly two different organs. They are not related. Breast cancer can't spread from one to another, and they develop differently, which is why some women are able to breastfeed out of one and not the other, and why other people are also able to have pain in one but not the other. And so when you look in the mirror, make sure that your right always looks like the right, and make sure your left always looks like the left. And although they aren't the same, let's say you're looking at your breasts and one nipple looks like it's pointing forward, but the other one's pointing to the side. Yeah, that might be a little different. Now, that doesn't always mean something's wrong, but that is definitely a sign to make sure somebody gets it looked at, to be like, why potentially did this nipple look straight last month, but ultimately with a slight deviation this month? So overall, breast cancer unfortunately is common in America. If you have dense breast tissue, which is A, again, doesn't make you an alien, and B, 50% of the population has, be aware that there's extra imaging you can get at the same time of your mammogram, read by the radiologist at the same time, which will help improve visualization. Why does that matter? Because early detection is less treatment and better survival rates. And although maybe not popular with the American Cancer Society, I absolutely firmly believe in having yearly breast exams as a woman. Thank you for letting me talk. And as most of you know, if you do know me, I do talk really fast, but it will take the rest of the time for questions and answers.
Okay, so I'll be fielding our questions and answers today. I'll start by saying thank you, Dr. Padilla. Excellent talk. I wrote a couple things down that I wanted to add. I think that consistency is key with these screenings. Like, we want to know a change over time. So it's something that you should be doing every year for yourself. In terms of the clinical breast exam, if you're going to the doctor and you want to have your breast examined, you just ask. We are all doctors, we're all capable of doing it, and we all should be doing it for you. And last but not least, we talk about self-care, treat yourself. Part of self-care is showing up for your own exams. So I think that you should treat yourself to exams, screens, mammograms, whatever is appropriate for you. That is part of your self-care. And I'll get off my soapbox about self-care and I will
It's
go
a
to
good
the
soapbox.
Q&A. Okay. Um, First question was, this is wonderful to learn. Thank you. Can we please get these slides or a video to share with family or friends? I actually don't know the answer to that.
I would assume yes.
I would assume yes, but I'm not the boss of that. So
I can
I'm
jump in really quick. Yes, you will receive an email with a link that will take you to all the webinars.
Perfect. Thank you.
okay. Perfect. All right. Second question. I heard a story of a woman that had breast cancer, but it was found in her arm. How would you check it in her arm?
Great question. Okay. And I wish I had a picture to show this to you. Um, okay. So interesting. Breast cancer, if it were to spread, it has to spread to the lymph nodes underneath the arm first. It doesn't skip. It doesn't go breast to brain, breast to liver. It has to go to those lymph nodes. And so when we hear about breast cancer being diagnosed in the arm, it was that it was actually found in the lymph nodes underneath the arm. Usually there has to be a tumor in the breast to then spread to the lymph nodes underneath the arm. But I did say usually there are these other types of it, they're not rare, or there, excuse me, there are rare instances, but they're not uncommon in the sense that we don't know how to treat it. But there are times where when a woman gets their mammogram, the lymph nodes look funky and they can't really see the mass in the breast, but they do see an abnormal lymph node and it is diagnosed as breast cancer. Now, when that happens, we do try to do extra imaging to prove that there isn't something in the actual breast, but it actually can happen that you can have breast cancer in the lymph nodes and not actually see or have a primary tumor within the breast tissue, which is a little crazy. But it can happen, and that's okay as long as we find it. I do want to make a comment about how do you, like you said, how do you find it? I don't know if you've had a mammogram and you notice that they actually go at you kind of at an angle. In fancy words, it's called a medial lateral oblique. And what that does is it does it at an angle and it actually gets parts of your underarm. So even though, so I don't know if you've ever had a mammogram, they like milk your breast tissue and they try to pull it in the machine. It actually is getting parts of your underarm and those lymph nodes. So you actually can see that part of it even on a mammogram.
Perfect. I fully agree. All right, another question. I have some breastfeeding struggles that led me to be diagnosed with insufficient glandular tissue. How would this condition impact mammograms or the ability to spot cancer?
Um, I feel your girlfriend. I don't know if I officially got diagnosed with it, but I also was not able to. So, but no, it doesn't actually impact your mammograms. At the end of the day, there is still glandular tissue. You may not have had enough to produce milk, but that doesn't mean that there is not enough glandular breast tissue to image. So it's not going to affect your ability to get mammograms. You should absolutely still get your mammograms. I hope that answers your question.
Yeah. I will say, just as kind of a caveat, if you are lactating, breastfeeding, and you're due for your mammogram, you can still get your mammogram while breastfeeding. There's
Yes.
absolutely no reason why you couldn't do it. The only thing they recommend is that you breastfeed your pump right before so that you can get all the milk out and it doesn't kind of cloud up that picture. But you can totally do it. It will not affect your baby or your milk supply. Next question is, does any of this information change with dense breast tissue and breast implants?
Good question. No, it doesn't. So the implants, if you have implants or an augmentation, most of the time it's done underneath the muscle. So those implants are sitting behind the muscle, not behind the breast tissue. But that being said, your density is your density, regardless if you have breast implants. And one of the things I always hear too is that if I have implants, A, am I able to get a mammogram? And then B, is there any harm to my implant by getting a mammogram? And the answer is no, for two reasons. One is that implants nowadays are basically virtually indestructible. But number two is there's actually special views that they will do. If you let the techs know that you have implants, they'll actually do your mammograms a little bit differently so that they are not allowing, so that there's no impact of the implant on the visualization of breast tissue.
Perfect. Okay. This one's kind of linked to screening and genetics. My 23andMe said I'm an increased likelihood of breast cancer. What do I need to do? And is there any extras beyond screening?
Great question. And I don't mean to be on a soapbox. I'm going to be on a soapbox slightly about this. So I actually love these tests. I think they're really cool from an ancestry standpoint. The hard part is that when it comes to talking about genetics for cancer, the labs that are used for 23andMe are not the ones that we use for regular genetic testing. They're not only, the last study I read showed that maybe only about 40% of them are actually accurate. So I would tell you that if that is the case, if there's a breast surgeon that you have nearby, or even if it's coming to see me or Dr. McAdams, I would actually recommend that you see a licensed genetic counselor to talk about that, to see if what that 23andMe lab said is actually accurate.
Yes. And there's another one about genetics that I'll answer real quick. Are there other cancers in your family that can make you at increased risk for breast cancer? And yes, that's true. That's why it's worth visiting a breast surgeon or somebody that knows more about genetics, because there's a lot of interconnectivity amongst your genes. So that is an excellent question. Let's see. When should I have my ABIS as a supplemental screening? Should it be in conjunction with my mammogram or at a different time interval?
I would say best image is if it's done at the same time. Then the same radiologist is reading your mammogram and your ABIS at the same time, and that's going to give you your most accurate read.
Okay, perfect. The next two ones are people that are survivors. 5-year survivor, 2-year survivor. Love it. Awesome.
Yay.
Okay. Those are just comments. Warm your heart. Okay. I've had issues in the past with callbacks. Can we request an ultrasound or MRI when we make our annual mammograms? And do you know the insurance implications of that?
Yeah, I think you and I live the same life. Yes. So I'm going to go back to mammograms are meant to find changes in breast tissue. And so if you have dense tissue, your breast tissue is changing pretty regularly. And so I am not at all surprised that you're being called back. The hard part is it does create a lot of anxiety, and I've chalked it up to this is just kind of my future for right now while I continue to have dense breast tissue. And so that's why I would say that getting this automated ultrasound with your mammogram would be really important, because you don't need to have a diagnostic mammogram per se, meaning after they find something, they do this extra imaging and handheld ultrasound. But that will help the visualization, and ergo, as you are pointing out to, if you have better visualization, it will lead to less callback. So my recommendation would be is if you're that person, we need to have a conversation about your density, adding these supplemental screens so that you aren't getting called back as much.
And I think that's also why consistency is key. If we know you had something abnormal on a prior mammogram or a prior ultrasound, and we took care of it that time, your next image will know that it's in the same spot. And so you won't get a call back for the exact same spot unless it's changed. Right. Next question is, if you have a benign spot or a cyst, does it make it more likely that you would develop breast cancer in the future?
The answer is no. Now, that's the quick answer. I'm going to give you a kind of a longer answer. No, if it is truly benign, it is benign. Now, one of the things that we kind of call breast lumpy bumpy, but that's not a joke. It's actually real. They are truly made of lumps and bumps. So having a mass in your breast does not mean you have cancer. It's actually very normal to have masses in your breast. That's what they do. So having something benign in your breast that is truly benign is absolutely not going to turn into cancer. That's just part of your normal anatomy. Can you have other things in the breast that can be considered high risk lesions? Absolutely, but you would have been told that. If it came back completely benign, then it is completely benign. If it is high risk, then they would have told you that this is, although not cancer, does require some form of follow-up.
Okay. Another question, does having larger breasts have a higher chance for breast cancer?
Great question. No, unfortunately.
No,
having breasts are breasts, regardless of the size. The risk is the risk.
Correct. Here, I have a question since we don't have any more in there. Dr. Padia, will I get cancer from the radiation from my mammogram?
Great question. No. So there's a lot of information out there about, yes, at the end of the day, a mammogram is radiation, right? And so the question is what is the amount of radiation in a mammogram? And B, is getting it yearly going to increase your risk of developing a form of breast cancer? And the answer is no. You actually get more radiation by being in an airplane and going from Columbus, Ohio to Washington, D.C. than you would by getting a mammogram. So those things are studied though. It's not that we recommend these things and haven't actually looked at side effects. It actually has been studied, which is why that number is 40. And we didn't say 35, et cetera. So no, if you get a mammogram starting at 40 yearly, you are not increasing your risk for breast cancer. You're not increasing your risk for any other cancer.
Okay. Let me see. I'm just going to quick read this. I had my last physician breast exam last October and mammogram in November, and then my first AVIS here in March. Good for you. My new PCP said he would not do a breast exam, and I'm on Medicare, so I'm not sure who I would go to get a breast exam. I no longer see a gynecologist since I don't have a hysterectomy. Do you have any recommendations?
Yes, come see us.
Yeah.
So we are a breast surgery office, and I realize that, but I'm going to say this as not everyone in our office needs surgery. So I'm definitely going to echo what Dr. McAdams said. This is your self-care. We are more than happy to see you on a yearly basis just to do your breast exam, and I do. I will have most likely nothing important to tell you, and that's phenomenal. But that's the best type of office visit out there. So at the end of the day, I'm going to support that you need to have a breast exam. And ultimately, if we see you just for that, then that maybe wards off the evil spirits and nothing will ever happen. That'll be phenomenal.
Yes, we love seeing people that don't have problems.
Yes.
We see the full spectrum of disease. So we see benign breast diseases. We see cancer, obviously. We see people that are at high risk because of a genetic problem or a very, very high family history of breast cancer. So we see the full gamut of breast care, and we're always happy to see you. Even if we don't really have much to offer you, we're always happy to answer questions because breast is kind of a very niche and odd kind of disease process.
Breasts are weird. I'm going to be really honest.
Yeah.
So, but no, to say
Oh,
one
go
more
ahead.
thing is that Dr. McAdams and I are actually, I am in the northeast in Westerville, and she is in the southwest in Grove City. So the hope is that wherever you are in the circle of 270, that we're close to one of us. So I'd say, I don't know where you live, but come find one of us. We're more than happy to be that person for you.
This is a great question that just popped up. In addition to lumps and changes in the nipple, what other changes might be concerning?
So I would say also any like skin redness, that would be one. So I know we talked about how like if your nipple looks like it's going the other way, if you have any changes to the skin texture or the way that it looks in terms of color, that's important. It may not always be a mass. And also if you're, going back to the nipple, it may look like it's pointing to the side, but also if it looks like it's going inward, that's also something. If you've always had an outie and all of a sudden you have an inner nipple, then that might be something to be like, this might be, I need to look at this. But it's usually the biggest things to look for, any changes on the nipple in terms of like if there's flakiness of the nipple discharge, the way that the nipple is pointing, whether it's pointing to the different side or pointing inward versus outward, and then any skin changes on top. So your breast tissue sits underneath your skin, but sometimes that overlying skin can also get affected. So that's where you have, what does your skin feel like? Does it feel thicker on the one side? It may not look like a different color, but does it feel thicker on one side than the other? Does it have a different color? Does it have a different shape? Callie, or Dr. McAdams, do you have any other?
You can call me Callie. I think another thing is if there's a real difference in feel. If all of a sudden your right breast starts to feel very heavy compared to your left one, I think that that's worth getting additional imaging for. Anything that just feels abnormal, it's always safer to just get the test and then have nothing to follow up on. I do have one. I love this question. Is there an age you should stop doing mammograms?
Great question. So I'm going to give you not a long answer, but kind of a little answer about this. The idea again of mammograms is to find subtle changes in your breast tissue. There are some groups of people, a specific task force that says that you should stop at age 75. There is a reason they came up with that, but the most common time to get breast cancer is in your 60s and 70s. So it gives me a little bit of anxiety to stop at 75 when that's your mid 70s. So what I usually tell women is that if regardless of your age, if you wanted to know, like doesn't mean you have to do treatment. Let's say you're 89 years old, you're very healthy. You don't know that you would want to do treatment, but you'd want to at least know that it was there and hear your options, then that is a time to get it. That would be and then technically from the medical standpoint, we usually say if your 5-year survival rate is high, meaning if you are fully healthy and we fully expect you to be here in 5 years without a problem, then yes, because getting your breast cancer treated early is actually going to impact the way you live the rest of your life. So I would just say if you're older and feeling like you don't know if you should get them, the answer I would ask yourself is, would I want to know? And would I want to hear options? If the answer is no, I'm too old, I don't really care, I wouldn't do anything, then fine, I wouldn't go do a mammogram. But if you would want to know, regardless of your age, I would say keep getting them. And then from our standpoint, regardless of your age, if we believe you're going to be here in 5 years without a question, then yes, we are going to continue to get mammograms. So no specific age cutoff. And I think we're actually at time. Is that correct? I should clarify. I know there might be some other questions coming in too. Would it be possible to get a list of them so Callie and I can answer them offline? Would that be possible?
I think there's only one left. So
Okay, great.
we'll do this last one. Regarding nipple discharge, when should you no longer be able to produce something from your nipples after stopping breastfeeding? And we'll make that our last question for the day.
Okay. So I'm going to kind of say two things. One of the things really is having discharge from your nipple even after breastfeeding. There is a difference between nipple discharge versus milk. So I would say if you're having milk production after pregnancy, hormones, etc., then okay, that could lead to something, not a bad thing, but could lead to something else. But having actually nipple discharge is not uncommon and is actually not always a sign of something bad. So now if it's new for you, I would highly recommend, like Dr. McAdams said, you need to make sure we get evaluated just to make sure it is nothing. But I would answer your question to say that it's not actually uncommon to continue to have nipple discharge as a woman. There's natural secretions that are always coming out of our breast tissue, usually on a microscopic level. And so it's not actually uncommon for that to happen. But if you're having milk production far out after having a child, that's a different story. Again, doesn't mean something bad is going on, but there's probably something driving some sort of hormones that we need to get figured out further.
All right. Well, thank you, Dr. Padilla, for giving this wonderful talk. I learned a lot, and I hope our audience learned a lot. If you ever need to get a hold of us, you can look at Mount Carmel Health, and we're both on there. I think that's all I have to say.
Thank you, everyone.